Good morning. Like she said, I am State Representative Ajay Pittman. I represent House District 99, which you are just a block outside of. So I don't have the convention center, but I have the street right next door. And I just would like to welcome you to Oklahoma City. Welcome to our beautiful home. I hope that you enjoy yourself while you're here, but I hope that you gain something from this panel. I hope that it's impactful. I have been a state representative since 2018. I got elected at 24. And so policy has been something I've been doing for a very long time. And it's very important that we share with you how we work with our experts, how we utilize data to affect policy. And that's really what this panel is about. So just to give you some acronyms, community-based organizations, CBOs, and faith-based organizations, FBOs, are uniquely positioned to champion community-forward policy. This panel discussion will explore the power of community mobilization and how CBOs and FBOs can inform and promote equitable policy on local, state, and federal levels to increase access to healthcare for historically marginalized and medically underserved populations. And without further ado, I would like to go down our row and allow my esteemed panel to please introduce themselves. Mr. Pancho, will you start?
Sure. Good morning. Am I on? Yes?
I think we can hear you.
Okay.
There we
I
go.
can project. Hi, good morning, buenos días.
Good morning.
My name is Francisco Arguelles. They call me Pancho. They call me all kind of things. When I was young, I thought my name was Be Quiet, but that's when you have older brothers and sisters. And I work with the Praxis project, which is a national capacity building organization that works with community-based groups to advance racial equity and racial justice. We work with a network of the willing of more than 200 organizations around the country who are working on all kinds of issues. And one of the things we say sometimes is that when you are part of a community that has been historically marginalized, you really don't pick issues. Issues pick on you. Mm-hmm. So today might be police abuse. Tomorrow might be gentrification. Could be also impact of disasters. I have been working on human rights and community organization for more than 40 years. I started really young as a rural teacher in the mountains of southern Mexico. And with Praxis now, we were doing capacity building, or a word that we use in the way I was raised in the movement, working in Central America and Mexico, the idea of accompaniment. Mm-hmm. See, that you actually engage in long-term relationship, supporting the effort of groups to build power and survive, resist, and transform. And I'm really grateful for the opportunity to be here, and it's an honor to be sitting here. I know there is a lot of experience and wisdom in those chairs. Any of you could be sitting here, so it's really an honor to be here and with my colleagues.
Awesome. Thank you so much for being here.
Good morning, hello, okay. Yo, hot mic, okay, cool. Good morning, everyone. My name is Francis Crevier. I'm what you call a bougie native. It's like Cartier, it's French. I am the CEO for the National Council of Urban Indian Health located in Washington, D.C. Our role is to advocate for the trust and treaty obligation of healthcare to our urban relatives in urban areas, which is over 70% of the population today, which most of you may not know that because most of everyone doesn't know that. And so we advocate to make sure that our relatives in urban settings are considered and taken care of in policy initiatives. And so we represent the 41 UIOs within the Indian Health Service. And we advocate not only for policy initiatives, but we do provide technical assistance and training to those UIOs, and are always, just fighting for health equity like everyone else. Just an honor to be here. Thank you.
Hi, good morning. I'm Vacheria. I'm the Associate Vice President of Policy and Regulatory Affairs at the National Association for Community Health Centers. So if you're not familiar, community health centers or federally qualified health centers actually were started in the civil rights movement. So we're coming up on the 60th anniversary of the health center movement is what we like to say. So there are about 1,500 health centers with nearly 15,000 sites across the country. We like to say there's almost a health center in every single congressional district except for like 2. But what I really value the most about health centers is that they are completely based on the needs of their community. So they fill the gaps where there aren't other healthcare providers. But even beyond that, before social drivers of health was this new sexy term, that is really the root of what health centers do. So they not only address healthcare needs, but the point of why health centers were started is because of structural racism and the lack of access to care, but also you can't really think about, taking your medication or making your doctor's appointment if you don't know where you're going to eat, if you don't know where you're going to sleep, if you can't get time off of work. And so health centers really address the whole person and whole person care. And so health equity is at the center of all of our advocacy at NAC because we not only advocate for what our health centers need, but also what the patients need, because 90% of health center patients are 200% or below the federal poverty level. So our patients need all the work that you all do here today, and we're really excited to be here.
Thank you, Dr. Lawson.
Good morning, everyone. Thank you. So I'm Dr. Yolanda Lawson. I am based in Dallas, Texas. I'm actually the immediate past president of the National Medical Association. I'm an OBGYN by specialty. And my work in community-based organizations, currently, I'm the medical director for a community-based organization who primarily deals with HIV disparities. I began my work really, though, in faith-based organization. Being the medical director of a pregnancy crisis center, and ultimately went and developed a faith-based STI screening program. And with the National Medical Association, we are divided into 6 geographic regions throughout this country, and we have regions and local affiliates. But a lot of that work, because we're grounded in eliminating health disparities, requires proximity to community-based organizations because we advocate right alongside with them. So thank you for having me this morning.
As you can see, we have some experts here, and we're very excited to hear about their knowledge and talk about community-based organizations and faith-based organizations. A little bit of information about Oklahoma, specifically my district, House District 99. I have about 81 churches in my district. We are in the center of the Bible Belt here, so faith-based community organizations are really big. The partnerships with our churches are one of our top initiatives within our communities because they are actually the ones really at the forefront of reaching the people. So without further ado, our first question: what are some of the community-based solutions that you have identified as being effective, and how can they be scaled to have an impact on broader communities? Whoever wants to start.
Yeah, I could kick us off. I think one of the things that's really successful, or 2 things that I would say, one area that we are really starting to grow more and have a lot of partnerships under the Biden administration is food is medicine. I think a lot of our health centers, what we saw during COVID is a lot of our health centers would have food pantries, but a lot of those community-based organizations did not make it out of COVID. And so what we saw happen was that they passed their grant to the health center that they knew because of our federal grant was able to sustain. And so we saw health centers really grow very vast food programs. So our board chair, her name is Paloma Hernandez. She's in the Bronx, and she has a health center that she actually took over from her dad that started. But they do something called food bucks, where they have urban health plan food bucks, where they're able to actually take these dollars to a grocery store. And so there's a level of dignity of how the patients are able to access this food. But we've seen that health centers are seeing patients come back more to be able to access those services. And then they like the way that the health center's integrating that with, before they start a visit today, okay, if not, go down to the 2nd floor and you'll be able to leave with they get that off the table. And the second thing is also the environmental health consequences that we're seeing from hurricanes. Health centers are open regardless if it's snowing, raining, hurricane, or whatnot. And so we've seen health centers take advantage of a lot of things around solar panels and generate to serve patients in these natural disasters, because if your house floods and you have no more medication, that is an emergency that sometimes isn't at the top of the list when the city's, right, trying to get streets open or trying to make sure the grocery store is open. And so seeing those policies of health immediate needs gaps is work that maybe wasn't started in the health center, and so leveraging partnerships has been really key in making sure our patients are aware of what's out there if we're not the one providing it, but then how can we provide those services, or how can we fill those gaps, and working in partnership with the community.
Absolutely. I think We're in an ag state, so look, we have a lot of land here, people. So if you see some things, if you see some deer, yes, we have them. We're big in ag, but food is definitely medicine. And even though I represent an urban district, we still have a food desert. And so a lot of people are very shocked by that. And so as the only urban member that sits on ag, food as medicine is something that we've been really trying to adopt here in the state of Oklahoma, and how, navigating how we replicate that in different urban and rural communities. Would anyone else like to tackle that question?
If I can,
Yes, please.
go, because I see the connection in response to disasters, right? I live in Houston, Texas for the last 20-something years. Don't let my British accent fool you, I'm from Mexico. But before joining Praxis full-time, I had been a consultant with them for like 20 years since Makani Themba founded it. But I was the director for more than 10 years of a local community-based organization called Living Hope Wheelchair Association, which was formed by immigrants who suffered catastrophic spinal cord injuries and became quadriplegic and paraplegic. And because they were uninsured and most of them were undocumented, we have public policy in the city with the largest medical center in the world that say you don't qualify for catheters or diapers or wheelchairs. You are excluded. Now talk about this hierarchy of the value of life and suffering, no? Like it's structural. It's like your body cannot work anymore, so it has no value and is pushed to the side. This group did what our communities do when disaster strikes, and disaster doesn't have just to be climate. Policies are disasters too. And they came together and organized and did things that I have seen work. Mutual aid. Respond to survival needs before getting into big mobilizations about bigger visions. Like responding to survival needs is what gives community-based organizations the legitimacy to then get to talk about larger things. If I show up to somebody who's struggling to survive or to get diapers or food or stuff, and I start going blah, blah, blah about my campaign, and I am not relevant to their fight for survival and their suffering, then I don't really have the right to ask them to mobilize for anything. So this connection between services and response to disaster is key, and Living Hope was able to respond to Hurricane Harvey, became like a hub where, and it's amazing, this was a group run and built by immigrants in wheelchairs, and I for a long time I was the only person not in a wheelchair working there, and most of us, we were volunteers. Wow. But at some point, my brothers there took so much pride of being able to give wheelchairs and catheters and diapers to American citizens, even veterans who were not getting responses from the government, and say, like, we don't say no to anybody because we know how it is not having what you need to live with dignity. So this capacity to respond is essential, and the other is build a base that is rooted in the leadership and the wisdom of the people who are navigating that suffering.
I mean, that, Dr.
I want to
Lawson.
speak to that at a broader level, because I think it's so important for us to understand the importance of public awareness too, and how community-based organizations historically have played such a large role in that. I think back to Margaret Sanger in 1916 starting Planned Parenthood. That started as a community-based organization, but now we look in this country, much of the reproductive justice policies, right? We need Planned Parenthood, right, from that perspective. You think about We Act now, environmental justice. We Act started as a community-based organization. My colleague here just talked about FQHCs, the civil rights movement. In Mississippi, the National Medical Association physicians there in Mississippi came together because they knew, right, Bloody Sunday, that those protesters would suffer wounds and injuries medically. Those doctors came together in Mississippi, NMA doctors, and then out of that movement in taking care of protesters during the civil rights, FQHCs, what we now know today, was born out of that. And so for me, much of it, when we talk about this role of advocacy, we talk about the role of public awareness first. We need to be aware there's a problem, and so often community-based organizations lead that. And probably the greatest example of that would be in HIV, right? When you think about the awareness and the advocacy that took place to get us to where we are now, right? From an awareness for all of us, for the policies that have been formed, it really came out of community-based organizations and the advocacy put forth through them.
Love that.
Yeah, so one of the things we were talking about effective solutions that we found, so in our urban Indian organizations, I mean, even having urban Indian organizations are a result of termination and the relocation, era where it was kill the Indian, save the man. And not until 1987 UIOs were started as they were moving natives into urban settings to say, our healthcare, you still owe us this. This is still our trust and treaty obligation. And so the fact that I'm even sitting here today as a result of those UIOs just fighting for our rights to make sure we still had access. One of the things, our voting is now, right, a social determinant of health. And we've, and it is, and it is.
Yes.
And the last election, Arizona turned blue a little bit, right? And so our Arizona facilities are, now right now they have, our facility in Phoenix has voter registration right there. They're the first ever Indian Health Service national voter registration access point for natives. So that while you're waiting, why not register to vote while you're waiting for your doctors? And so using those types of solutions to kind of progress us forward and just be proactive and partnering. A lot of our facilities have youth councils, and so how do you get the message out? How do you healthy behaviors, healthy education? And so we always have a lot of youth councils in general. Within a lot of Native organizations, you usually see a youth council. And so it's really to help, share multiple perspectives to make sure you're thinking about multiple generations, because they're always going to see things you don't, right?
Can I add on to the voting piece? Because that's a lot of work that we're trying to do. Health centers are bipartisan, so we're not telling people who to vote for, but the folks who come to the health center, right, I said 90% or 200% are below the federal poverty level, often feel like they don't have time to care about politics. They don't have time to care about who's being elected, but they're the ones impacted the most. And so we try to do work around just understanding the importance of your vote, just understanding what it's connected to. And Rep. Pittman, I'm sure you feel that, right? You're a local leader. And so we try to do a lot of education at the health center where we're not telling you who to vote for, we're not telling you what policies, but literally just understanding the fundamentals. We had a health center that pulled patients together to get a speed bump. The reason they got a speed bump on the street was because kids kept getting hit. And so they were able to organize through the health center to get these speed bumps placed on the street, which felt very small, but actually had a huge community impact. And so a lot of work is connected to people understanding you have power. It doesn't matter if you're living in poverty, it doesn't matter if you have multiple jobs, but your vote has power, but the people who are being placed in these positions have a lot of power over you. And so that is very key work in communities where they don't make those connections and all these things are coming at them. But if you are able to educate them, like those votes turn things around at a local level, which really has more of immediate impact than a lot of things that are happening at the federal level.
Absolutely.
Very true. I mean, the common thread that we heard with those responses is meet people at their social reality, have multi-generation connection, and empowering their voices, whether it's about voting or whether it's about their health care. And I think all of those are important, which leads me to my next question and kind of my next hat that I wear. I am the secretary for the National Native American Caucus. I sit before you as a member of the Seminole Nation of Oklahoma, and so we're excited to have the National Native American Caucus be a partner of this Health Equity Summit. But in that, as we speak to amplifying voices, as you navigate empowering voices, how do you amplify the voices of people that you serve to help develop policy, and how do we duplicate some of those things?
So I like to, Congress, so I work on the federal level mostly, mostly Ollie. But what I find is that Congress likes to say they don't they need data. They don't have enough data. The data's not accurate. There's not enough data. And it's very hard. Do a study.
Do a study.
Do a study. Let's do a study. And, as a Native person, sitting at 11 years less life expectancy than the rest of the country, one of the highest suicide rates in the nation, all of the health disparities. CDC before COVID talked about, CDC in 2019 published a study saying there's a public health emergency in Indian country and decision makers need to act before COVID. And we died higher than 85-year-olds, even though we were more willing to actually take the vaccine for COVID. So there's a lot of work that needs to be done. And so when I got, my background is in Indian law and policy. I went to the University of Arizona, go Wildcats. But what I found very quickly working on the Hill is, they don't want to move. And so you need stories. And so with the Indian Health Service, similar to the VA has advanced appropriations, which means that if the government shuts down, the VA does not, and their healthcare continues. But if the government shut down, the Indian Health Service shuts down. And what that means is don't get sick after June. That was a joke back then, because you might not have funds. The facility might be closed when you are about to die, and you might die. During our last shutdown of one of our facilities alone, one of the facilities alone, we had 5 fatalities during the shutdown for one facility. So we made sure to market that. We made sure to testify to Congress, to write reports, to easy one-pagers. The Hill folks, they're inundated with information all the time. And so getting I pushed the budget even of our facility. That facility, it was 5 opioid overdoses. They get less than $100,000 for the year for mental health. Wow. They get $1 million to operate 2 facilities, one in Baltimore and one in Boston. $1 million is all IHS gives them, and yet expects something. So telling that story, showing that impact, how is this actually impacting on the ground? Making sure that they're seeing we are dying of preventable things. Yeah. And what that led to was advanced appropriations for the Indian Health Service for the first time in 2022. And that is the first time we didn't have a shutdown. Now, it's not permanent, so we still have to advocate for it every year, which is so sad, because we will die if our facilities shut down. It's who gets who, it's insane. And so really just bringing those stories to those decision makers, because a lot of those folks come from a lot of privilege. And I should take a step back here. I am an urban native that I did not live in a location that had an Indian Health Service facility. I didn't have health care until I was 25. I was homeless at some points during my childhood. I never went to a dentist until I was 20, which has led to chronic illnesses for me forever. And what I want is for that to never happen again. And so those stories are very important because when I walk into these rooms of privilege, I realize, oh, you've never been homeless. You've never had to look for Medicaid. You've never tried to sign this, you tried to log in and the Medicaid website doesn't work. And some of the decision makers have really, one of the congressmen that talked to us on a panel, he was like, do you guys get to retire? And I was like, our life expectancy is 65. Do we get to retire, or do we die before we get there? So really breaking down that privilege. So because they don't know, and a lot of time it's not their fault that they don't know, but that's where the stories come in, because it can really help them understand.
Go ahead. I get so excited.
I know.
And I had that reaction when you say, how do you amplify voices? And part of me is like, to whom? Who's listening? And are they listening respectfully? Because when I try to talk to academics, sometimes it is like they're trying to just listen to respond with things that validate the existing theories, the pre-existing theories. No? So with my work with Living Hope, with immigrants, my wife's very active working with groups trying to prevent migrant deaths in the Texas-Mexico border. She has a project called the Cemetery Survey, just to go find the cemeteries where migrants are being buried unidentified. And we have thousands of migrants dying in the Mexico-U.S. border over the past decades because of the criminalization, militarization of migration. And again, policies kill. And they knew one of the outcomes of those policies was going to be death. But so when I want to amplify those voices, am I going to talk to a mother or a sister who's fighting to try to find their disappeared loved one? And I'm going to bring them to a space where they're going to be listened to with dignity and respect? Or are they going to be reduced to a problem to be solved? And one thing we say sometimes to researchers that came to us to try to collect evidence was like, if you're not willing to denounce the crime, stop collecting evidence. Because what's happening is criminal. Immigrants are being right now used as fodder for political things with a discourse that is horrifying, and that leads to violence. We know the massacre in El Paso, Texas, was a direct connection of someone who was fed with xenophobic racist attacks and went to the Walmart to kill Latinos and Mexicans. So we know this hate speech leads to that. So it's hard when you see of the size of the media universe and then elected officials who are decision makers but not necessarily representatives. Yeah. And are going to bring our community to talk to them. Are they going to be listened to with respect? So I'm not sure, and you still need to do it. But one thing we do in Praxis, we use a methodology called learning circles. We use popular education, which is a methodology from Latin America, being just for many decades, in which you center in the wisdom experience of community. And one way to amplify voices is to create spaces when we can be together listening to one another with love, respect, and compassion, and validate our own voices, reclaim our own voices in storytelling. Just what you were doing right now, just like getting into naming what we have been through and just honoring that. And from there connect to a kind of strength and power that can really change things. Invest in that for the long run, like open spaces like that, when we can hear each other's voices.
You said something that leads me to my next question before we start taking audience questions. In September, I had the pleasure of being on a panel for Mental Health America with my good friend, Moderator, who you'll hear from later this afternoon. But our session was about how data meets policy. And so my question to you guys is, how can CBOs collaborate with other community leaders to positively affect policy, but give tangible examples or tangible actions that people can take to talk to their elected officials or talk to their legislators, right? Because you can change a policy at the local level, like you said, easier than you can at the federal level. Sometimes we're a little bit closer, but people don't know the difference between city government, county government, there's a county community health center, there's a state community health center, but also people have to come see us and they have to come talk to us. And if you're not changing laws, then you're not changing policy for generations to come. So how do you guys navigate changing that policy?
So I'll start here because it's so important. Whether I'm a physician leader, but there are leaders throughout this room, right? We can be a conduit. So I talked about this a little bit yesterday, that sometimes we have proximity, right, to legislators and power that our community does not, right? But how do we be that conduit? Couple ways. I think back in 2022, there was a drug that was removed from the market that we as OB-GYNs used to prevent preterm birth. Who in this country has highest rates of preterm birth? Black women, right? And so I remember in testifying before the FDA, but I brought patients with me, right? I brought my patients who had lost babies due to extreme prematurity. And subsequently, with using that medication, we're able to successfully have babies that they were able to take home with them that are living healthy, thriving lives. So that piece, the conduit in us bringing in the community with us. And then secondly, on the data piece, so I testified before the Senate Health Committee, and one of the things I was talking about was discussing maternal mortality. So CDC has the data, but the senator in the room said to me, I have questions about the data. I've had questions about the interpretation of the data. So we talk about the data, we have the data there. People in the community is tired of the data. We keep hearing the same thing. And then, but the data is always questioned. Who interpreted it? How is it collected? So even when you have a body such as the CDC, which you all provide a budget for to help you collect the data, it's still in question by our leaders. And so we have to stand up against that, right? Because it's a problem. And we need the data. We all understand that as leaders and as scientists and as physicians and whomever. But again, how do you play that to make the community also trust it? But when you have separation, and we have our leaders and our legislators who are questioning the data, what does that do to the community who is already non-trusting?
I just love this panel. Like, can we be up here all day? But I think, you know, my two colleagues right here who are sharing their lived experience is the core of how you represent the populations you're advocating for. And so health centers are required to be 51% patient-led boards. And our health center board members are doing that for free. They are having monthly board meetings. They are overseeing what services the health center is providing, the gaps in care, patient populations. And our health center board members are the best part of the health center movement because they have full-time jobs and they are doing a separate full-time job. And it's usually because the health center saved their life. And one of my favorite things is always asking a health center board member, how'd you find the health center? And it's usually, my mom didn't have access to this, or I didn't have access to this. And so once I realized this health center was here, I've been on the board 20 years. I've been on the board 15 years, or I've come off, come on, come off, come on. And then they leverage their expertise in what they do in their day-to-day job to help the health center. But I think one of the most powerful things is we, from NAC, use our patient board members to do the best part of our advocacy. Because you can hear from me, who's like, you know, all DC, and I know all the acronyms and all the words, but when you hear from you know, a patient board member who talks about how the health center gave them for the first time, you know, 3 months of insulin for $8 and how that changed their life.
Wow. Because
you can't ask someone, you know, Congress right now is, we're gonna fix diabetes. We're gonna fix diabetes for people who have insurance. Like, let's get a policy for Medicare. Let's get a policy for this, for people who have insurance. There are people without insurance who cannot get access to medication, and I'm talking to representatives at Congress about how can we have someone else who has insurance get medication for $35? Not saying that healthcare in America is perfect, right? And we know that if you have insurance, you still can go without, but we are talking about the wrong people. Like, there are people who have no access to insurance, and we are talking about the people who have insurance. And then when I bring up the uninsured, it's like, oh yeah, that's very important.
Thank you.
And the solutions don't match. So when I put a board member in front of them and I'm like, let them tell you how the health center is giving them all their medications, giving them food classes to teach them how to cook healthier to solve their diabetes, giving them not just the insulin, because you need more than insulin if you have diabetes. You probably have other chronic conditions that you need that medication also at a discounted rate. It's like they're in a vacuum, and these patient stories centering the people that you serve and allowing them to have a voice, it zooms the conversation out. Because if you talk to somebody who's a diabetic, they will tell you the insulin is 1 out of the 7 things I need at a discount. And so that's the work that we try to do, is that people don't live single issue lives. And so if the solution is only on one issue in their life, we're not addressing whole person care, which is the root of health equity.
Amazing. Thank you so much for those answers. I want us to be able to hear, at least take 1 or maybe 2 audience questions if you guys, if we have some, because I know we're running short on time. But as you hear, these people are at the center of the work. They are at the center of leading the work. And I think navigating that policy aspect is very important to making sure the work continues. Do we have a question?
Hi, good morning. I'm Renika Alexander Parrish, and I lead health equity for the vaccines and antivirals group at Pfizer. And one thing that is really concerning to me, and I haven't heard the alarm bells as loud as I'd like to hear them, is the Medicaid unwinding that has occurred since the expiration of the public health emergency. So there are people who are losing their benefits, the churning that, I think about, from way, way back in the day in my childhood when you show up and then you don't, your Medicaid is cut off. How many people, is that happening to now? You talked about people being uninsured. How are we capturing those folks? And I'm thinking about the resources that are now being put into making sure people get notices and just trying to get them coverage that could be used to provide services. So I'm wondering what the challenges are that you're seeing, and then what are some of the solutions that maybe you've had locally in your states or in your particular entities?
Yeah, I could just kick that off because Medicaid redeterminations really impacted health centers. So about 50% of our patient population, health centers serve 32 million patients, are on Medicaid. And health centers are required to do outreach and enrollment, which means it's as soon as you walk into the health center, we get your name, we talk to you about what insurance coverage you have available, and we do it in a way that really makes them feel empowered. And so our data shows that health centers on average lost about $500,000 because of Medicaid redeterminations, and health centers operate on very thin margins. And so what we're seeing is that there's extra legwork required, and they're having to repurpose the 2 people who did eligibility to now someone maybe in accounting, someone maybe who was on the front desk to just enroll people. But we're also getting people from the community. And so what we're seeing in states is that health centers feel like they are back at pre-ACA levels of uninsured rates. And it's hard to put your finger on the button of how we get here, even in states that are very Medicaid friendly, but there's a few things. Medicaid agencies are understaffed. So they didn't have the staff to run the Medicaid program and then to also do the unwinding, which was part of the challenge, which we try to tell our health centers to have grace for, that the same way you're understaffed is the same way the Medicaid agency is understaffed, and they're repurposing people. But then also, too, health centers see everyone regardless of their ability to pay. So when that patient walks in and we discover they don't have Medicaid, they're still seen today. And so part of the financial challenge we're seeing is that now is doubling the uninsured rate of who's walking through the health center, and you can't always back bill. And so when you think about the resources in the community, our federal grant is for the uninsured population, but our federal grant hasn't grown in a long time. And so we need every dollar, we need every patient that's eligible to be on coverage if they can be, but there aren't enough hands involved in Medicaid redeterminations to catch all these patients who are still eligible. They just got churned off. But we saw states where Florida, there's a lawsuit against the state. Arkansas finished it in like 6 months. They were like, yep, we done, we redetermined everybody, AKA we kicked everybody off. And so we've been, we just had a meeting with Administrator Chiquita Brooks-Lesor to say there's still harm happening. Just because Medicaid redeterminations on paper is finished, our health centers are seeing it every day and the impact, and that, this administration, the next administration, this Congress doesn't want to talk about it, but there needs to be an investment to get patients back on care, because we saw what happened in COVID flexibilities when people were able to get the vaccine and didn't have to wonder about how they paid for it. When people got to stay on Medicaid and didn't have to wonder about how they were going to stay on, healthcare was actually working in the pandemic. And so rolling these flexibilities back, there's generational impact to that.
And I love the specifics of that, on how to navigate that. And I will connect it to like the longer term, the long game, like Dr. Christopher was so inspiring on reminding us on how it is a long-term resistance. They have been denying, doubting our humanity for centuries. So of course they're going to doubt our data if they are doubting our humanity. No, but then to face these kind of challenges, and coming from Texas, when we have 2 governors in a row refusing to take Medicaid expansion money, and we see people who should have access not having it, then imagine how it is for undocumented immigrants. For sure. No, who they just get enrolled on emergency Medicaid while they need emergency care, and then they are sent out, and all the impact, long-term impact on that is like you have emergency humanity for a moment, and then we ignore it, no? So for me, the long-term question is, how do we build power to change not only who is representing our communities, and not just whoever is paying for their campaign, but actually our communities. So for that, we need a base in zip codes who's organized and with leaders there who can go represent, do the research themselves with support from partners, interpret it, but also bring the stories, bring the power. And we can bring data telling them, we have this many people in your district that are going to vote, or even if they are undocumented that cannot vote, they can go door knocking. That's what the Georgia Latino Alliance for Human Rights did in Georgia. No, they mobilized thousands of undocumented immigrants to get people out to vote. That power building, I think, is essential to changing the conditions not only of the policies, but actually who makes the policy and the structures themselves, and that takes decades. No, and Praxis was lucky to be part of an initiative with the Robert Wood Johnson Foundation called Communities Creating Healthy Communities, in which many community-based groups around the country were able to mix that part of services, research, and base building to change policy, but also build power for the long run, defining who gets elected, and at some point getting people from the community elected.
I think that's important, and I know we have to wrap up, so I apologize that we can't take more questions, but these experts will be here throughout the day for you to be able to see them. But the takeaways for me are meet people at their social reality, use your proximity to power to build more power, and to make sure you carry people's stories with you. So thank you so much for your time, and thank you so much for listening to us.